How often do antidepressants actually work? The real answer is...
I'm Dr. Kristen Holmes. Dr. Chris Palmer is a psychiatrist advocating for new types of treatment for mental illness.
Millions of people are suffering from treatment-resistant depression, trying medication after medication.
There are side effects of these drugs.
Slurring their speech, tics. What are we doing to these human beings? Giving people SSRIs is not enough. That's why I became a psychiatrist. I went into it to try to be better. I want to help the people that other people can't. I'm proposing a somewhat audacious theory. Metabolic dysfunction can be the first sign of mental illness. It's not always psychological.
How did you know, okay, we're going to try a ketogenic diet? Where do you even begin?
Begin with
When was that aha moment?
the brain scans of people with severe mental illness will show.
That seems crazy to me. There are so many distractions in our modern lives that are holding us back from reaching our full potential. If you're here, I guess you're feeling ready to change that and explore what truly matters in your life. We're bringing you thought-provoking conversations and topics every week that will help you focus and unlock your performance and become your best self. Make sure you don't miss out. Please subscribe and don't miss the opportunity we have together to reflect, grow, and create the life that you aspire to. I wondered if we could start. I'd love to read the dedication in your book that you gave to your mother. Can I read that?
Sure.
My futile attempts to save you from the ravages of mental illness lit a fire in me that burns to this day. I'm sorry I didn't figure this out in time to help you. May you rest in peace. I think your journey is, equal parts heartbreaking and inspiring, and I'd love for you to just reflect on that dedication, if you don't mind.
It's really interesting because when I wrote the book, I initially made the decision to not include any of my own personal story or my mother's story, because I'm kind of proposing a somewhat audacious theory, and I knew that people might be skeptical, and that if I acknowledge I have mental illness in my family, that might just hurt my cause and hurt my credibility. And as I was doing the dedication, I just recognized, she's the reason I became a psychiatrist. I can't not dedicate it to her. And I could have done something really simple, like to my mother with love. And I thought, but that's not at all honest or transparent. I mean, I love my mother, but that's not the reason I'm dedicating it. And the kind of quick story is that my mom actually lived 2 different lives. She grew up in actually a pretty wealthy family in Indianapolis, but there was a lot of alcoholism and abuse and trauma. It was chaos in that house. And she really wanted to get out of that and just have a normal, simple, middle-class life. So she found my dad. He was a pharmacist. And she worked her butt off to support him and to support his dream. And so both of them were working 12-hour days, 6 days a week. Meanwhile, having more kids, they end up with 8 kids. There are always little kids around. She's taking the infants to work with her, breastfeeding them. But for the most part, it was a pretty good life. And then some really horrible things happened in her family of origin, and is essentially put in a position where she's going to have to testify against somebody she loves, and it might result in the death penalty. And actually just has what she calls a nervous breakdown. She doesn't know what to do with that. She doesn't know what the right answer is. There isn't a right answer. And so it starts as what she calls a nervous breakdown. I think most people today would diagnose it as severe depression. She quickly becomes suicidal and then develops psychotic symptoms. She becomes delusional. She thinks she's Mary Magdalene reincarnated. She's going to this priest for counseling. She begins to believe that he's Jesus Christ reincarnated. The end of the world is coming. Everything's aligning. We're right at the center of it in good old Fort Wayne, Indiana.
Oh my
And
gosh.
she's getting paranoid. She's making erratic decisions. That ends up resulting in my parents getting divorced. And she ends up losing literally everything. She loses custody of all 8 kids. I was 12.
Goodness.
And she loses ownership of the business. They don't give her any of the savings. She got the van, and she got, I think it was something like $55 a week in support. And her rooming house room was like $60 a week.
My goodness.
I never really got along with my dad and was horrified that my mom is psychotic, depressed, suicidal. She's going to die. So I go to live with her. We end up homeless. We stayed at the rooming house as long as we could, ran out of money, end up in a homeless shelter. And that's where I'm at my first day of high school. But the tragic news is that for my mom, she was getting mental health treatment. She was hospitalized involuntarily, actually. She was seeing a psychiatrist. She was taking the medications, the antipsychotics, the antidepressants, the sedatives, the mood stabilizers. She was taking all of them. She was doing psychotherapy, and she wasn't getting better at all. She looked drugged. She was slurring her speech. I remember her mouth was like so dry, and she would like just open her mouth and you could hear it, how dry it was. And she was still crazy and still suicidal and still depressed. The tragic fast forward version of all of that is that she never got better. She lived the rest of her life with good times and bad. But she lived the rest of her life with a chronic psychotic disorder. She didn't get mental health treatment ever again after the initial kind of med trials and other things. And I was hard pressed to push her to get treatment, even after I became a psychiatrist, because I knew the outcomes, it's not going to work. You've already been there and done that. You've tried antipsychotics, you've tried antidepressants and mood stabilizers and other things, and they never helped you. And I see patients week after week who are also on those meds, and they're not being helped. So I had to make this strategic decision as her son, like, she trusts me right now and she loves me. And am I really going to try to strong arm her into taking more antipsychotics when I know they're unlikely to really help her? I mean, she didn't live a horrible rest of her life. She was able to work a few part-time jobs, save up money, buy her own small home. But in the grand scheme of her life, it decimated her life. She lost everything. She lost so many relationships as a result of the delusions and the paranoia and everything else. And so at the end of the day, I'm often asked, why did you become a psychiatrist? And at the end of the day, even though I had my own personal struggles with mental illness and other things, I'm happy to talk about or not or whatever, but it really wasn't because of my own. It was because of her story. And I came to the mental health field essentially angry with the mental health field and so disgusted with it.
Yeah.
And that's why I became a psychiatrist. I went into it to try to be better, to try to do something different, to try to help these people who aren't being helped. And I went through so many phases when I was in medical school. Initially, I thought, no way in hell do I want to become a psychiatrist. No way would I ever do that. I hate that field. And then when I was doing my psychiatry rotation, I saw the same thing over and over again. These patients being forced to get treatment against their will, slurring their speech, with dry mouths, with tardive dyskinesia, with tics, with all tremors, with all sorts of things.
So all the side effects of these drugs. Right?
All the side effects of these drugs, and they're still crazy and disabled. And I'm thinking, what are we doing to these human beings?
Dr. Palmer, how many people go into treatment like your mother and don't get better? What's the data?
Tragically, the data is really poor. So it somewhat depends on the diagnosis. So for people with psychotic disorders, she's actually very much the norm. One large study that followed 6,000 patients who were diagnosed with schizophrenia, so the most common chronic psychotic disorder. They followed them for a few years and looked at how many of them got remission of their symptoms, how many of them had a decent quality of life, and how many of them were able to work or function in society. And when you put all three of those things together, they called it a recovery, and only 4% of the patients being treated at academic medical centers around the nation, only 4% got a recovery. And so that's psychotic disorders. Bipolar disorder, it's well accepted. Well, that's just a chronic disorder. You're going to be in and out of hospitals. You're going to have mood episodes. We'll do our best to try to stabilize your mood and keep you out of trouble and keep you out of the hospital, but it's expected that you're going to have episodes because we don't have cures for bipolar disorder. We're really sorry. We're doing the best we can, but that's the way it is. If you look at recovery rates from substance use disorders, pretty abysmal. When you look at bread and butter major depression, some people in the field will say 70% response rate. That's great. What they sometimes neglect to tell you is that, so if you come in with your first episode of depression and get treatment from your primary care doc or a psychiatrist, they will likely give you an SSRI, Prozac, Zoloft, Paxil, something like that.
Antidepressant medication.
Antidepressant medication. And, medicine that 1/4 of American women are taking right now.
It's just wild.
1 in 4 women, adult women, are taking these medicines. So these are very common.
Do you know what's the mean age? Just curious if you know.
The mean age
of women on SRI, does it skew? Is it in the 40s? I'm just wondering if it coincides with perimenopause, menopause.
So the interesting thing is that if you look at it as a percentage of the population at that age, it actually goes up over time.
Wow.
The older you are, the more likely you are to be on a psychotropic medicine, in particular antidepressants. And that will come back to my theory. I believe mental disorders like major depression are diseases of aging, just like the metabolic disorders are. But that is what the statistics show. And people will hand wave and rationalize it. Well, if you were in a nursing home, wouldn't you be depressed and on an antidepressant? Well, okay, maybe. Well, if you were old and all your friends were dying, even if you're independent and working out, wouldn't you be depressed? It's not unusual that these old people are depressed. That's the story we tell ourselves, but we're missing such a glaring clue that is like flashing red right in front of us. Like, no, it's not that. It's not always psychological. I'm not here to deny the psychology. Yes, I would be depressed if I was in a nursing home. No doubt about it. Yes, if my friends were dying, I would be down. I would be grieving. Yes. It doesn't mean I'd be running out on an antidepressant, getting on an antidepressant. Because you can make up stories like that for everybody. Well, if you were poor, wouldn't you be depressed? Well, if you were being abused, wouldn't you be depressed? Well, if you had people bullying you in school, wouldn't you be depressed? I mean, all of these things make sense. But the reality is the older you get, the more likely you are to be on a psychotropic med. But going back to so how often do antidepressants actually work? How often do they work well? The field will say 70% response rate. What that means is that some of your symptoms will be improved. But the real answer is with initial antidepressant trial, 30% remission rate. The other way to say that, so remission means that you no longer meet criteria for the disorder. It doesn't even mean that you don't have symptoms. Because to be diagnosed with depression, you have to have 5 out of 9 symptoms. So 5 or more of the 9 symptoms of depression to meet major depression. If you go on an antidepressant and you go from 5 symptoms to 4 symptoms, that's remission because you no longer meet criteria for major depression because you don't have 5 of the 9. You only have 4 of the 9. Now, those 4 symptoms could still be debilitating. They could be severely impacting your ability to function. They could cause tremendous suffering. But because you don't meet criteria, you are in remission. I don't mean to take away from the benefits of antidepressants. There are millions of people who do great on them. And for some of these people, they will say, this antidepressant saved my life. I am all for saving lives. I am all for reducing suffering. But we have to confront the reality. And the reality is that millions and millions of people around the world are suffering from what is called treatment-resistant depression. And what that means is that these are people with depression who are trying medication after medication after medication. Some of them are getting electroconvulsive therapy. They're applying electricity to their brains. Some of them are getting transcranial magnetic stimulation. They're applying magnetic fields to their brains. Some of them are getting ketamine injections. Some of them are going off trying psychedelics. And despite all of that, they are still depressed. And their lives are dramatically impaired. Many of these people are disabled. And
These are the folks that you treat, right?
These are the folks that I treat.
These are that you treat the treatment-resistant folks. So these are the people who are coming into your clinic every day.
Being at McLean Hospital, for better or worse, we have the privilege of being ranked one of the top psychiatric hospitals in the nation. And I think what comes with that, at least for me, in the roles that I've played there, are I get the patients that other people can't treat, that other people can't get better. Which has been fine with me because that was my passion anyway, is I want to help the people that other people can't. If another clinician can prescribe Zoloft and get them better, let them do that work.
Right.
I want the hard cases. You don't need to give me the easy cases. Give me the really challenging, difficult cases.
Would you say that that gave you kind of license to experiment a little bit? Within reason, of course, but
Absolutely, it did.
yeah, maybe talk about kind of what that path looked like for you. A patient arrives at in your office and they've had this probably a file this big of things that they've tried to get better. Where do you even begin?
My training taught me begin with a really thorough history, ask them all the details, make sure you get all of the diagnoses because so many clinicians miss it. They miss the PTSD diagnosis and the trauma history, or they miss the substance use disorder. They don't know that the patient is drinking 5 glasses of wine every night and blacking out every night. They don't know. And so that line of thinking is, if we just give the right labels, if we just give the right diagnoses, then we can really treat people. And it goes along with this sense that, well, the reason these people aren't getting better is because they're not getting the right diagnoses. The clinicians just aren't doing a good enough job. The next thing I do is I go through in detail. What medications have you tried? What treatments have you tried? And I go through all of the different categories of medications, antidepressants, mood stabilizers, antipsychotics, anxiolytics, other alternative things. Like, I'm going through everything. And usually when I do that, I come up with a list of, oh my God, you haven't tried much of anything. Even if they've tried 30 things. Oh my God, there's so many opportunities for us to try more medicines. Don't worry, don't panic. We will figure this out together. That's how I started my career. And I was actually running exactly a consultation service that did that, a psychopharmacology consultation service for treatment-resistant patients that even our McLean Hospital clinicians were stuck on and were trying to figure out, what are we supposed to do? What I learned within a few years of that is, oh my God, this isn't working.
Yeah.
And initially I was like, am I doing something wrong? Like,
Yeah.
what am I missing? I need more training or something.
Yeah.
More supervision or mentorship or something. I'm clearly getting something wrong, because a lot of my patients aren't getting better. What am I doing wrong? I quickly learned and was reassured by all of these brilliant, literally internationally renowned psychiatrists. No, Chris, you're actually doing a phenomenal job. You're doing better than most. Feel good about it. Pat yourself on the back. And I'm thinking, yeah, I know I got that one and that one and that one better, but what about the others? What about all the others? Oh, well, Chris, they've got chronic mental illness. That's just the way it is.
They can't be fixed.
We don't have cures. You need to accept that.
Mm.
And you need to help your patients accept that. Let them know that it's okay to have a chronic mental illness. Don't feel bad about it. Don't let that affect your self-esteem. You can still have a good life even if you're disabled. It doesn't matter that you can't get married and have kids. We'll figure out a purpose in your life anyway. Yeah, of course, that's a really shallow kind of promise and notion that we're going to help people have full, thriving lives when they can't function in some basic human ways. And when the rest of society looks down on them with either pity or scorn. So in terms of license to do novel things, I quickly started, probably the first thing that I really did, it was a little different, is I recognized that this term called iatrogenic harm, which means the treatments we're delivering are actually harming our patients. And I learned some of that through my own experience with my own depression and antidepressant treatment and other treatments. I certainly learned it from witnessing what my mother was going through. At the end of the day, she was definitely better off of medicine than on the medicine. Zero doubt in my mind. And so I started looking at all of my patients who came to me on 10, 15 medicines, slurring their speech, unable to walk straight lines, thinking, well, maybe you would be better off on a fewer of these. Maybe I can try to get you off some of this stuff. I wasn't alone. I wasn't a maverick. I remember one of my mentors, literally a world-renowned psychiatrist. She was the first fully tenured psychiatrist at Harvard Medical, female fully tenured psychiatrist at Harvard Medical School. And she would always say, whenever I would come and present these difficult cases when I was running that service, she would always say, if somebody's on more than 4 medicines, the first thing I want to hear is how you're going to get them off some of that stuff.
Nice.
Don't tell me about more pills. Don't tell me about other things they haven't tried.
Is that the first time you had ever heard that? Or was that kind of a common, like everyone was trying to get
It
their
wasn't
patients
common,
off?
unfortunately.
Yeah.
So she was a little bit unique. She, it was really interesting because I remember something that stuck in my mind is she said, this isn't just psychiatry. This happens in epilepsy too. When I talk to the neurologists, one anticonvulsant medicine can sometimes be a godsend and save people's lives. But when it doesn't work, when the neurologists add more and more and more anticonvulsants, one on top of the other, once they're on 4 anticonvulsant medicines, they're more likely to seize than if they were on none.
Wow.
And she said, I can't tell you how many neurologists I've talked to who, when they see a patient like that, all they do, a patient like that who's on 5 anticonvulsants and they're having 10 seizures every day, the treatment for that person is get them off some of those anticonvulsants, and then their seizures go down in frequency. That the treatments themselves are causing the very symptoms that they're supposed to be treating. I became convinced that antipsychotics can sometimes do that, antidepressants can sometimes do that, mood stabilizers can sometimes do that, that the more we medicate people, actually the more unstable and depressed and psychotic some patients can become.
Do you believe we should be scanning the brain?
I wish we had a brain scan that was clinically useful.
Yeah. But that's just we're not there yet.
I don't believe we're there. So others, won't name names, but
Yep,
others
yep.
will disagree with me
Yes.
and will say, absolutely,
Right.
we need to scan the brain. We need to look at the brain. The problem with scanning the brain is that what we already know from decades and decades of research, it's not that people haven't made a really kind of great attempt to find a brain scan that will give us answers. Neuroscientists, psychiatrists have been literally doing this since the 1990s, over 30 years. Valiant effort. They are desperately seeking a diagnostic test or something that will help us clinically. So what I'm saying, it's not for a lack of trying, it's not for lack of effort. Literally billions of dollars have been spent on brain scanning. When you put that all together, what we know is that it's different for everyone. The mentally ill, people with chronic psychotic disorders or OCD or other disorders, when you look at their brain scans as a group compared to a healthy control group brain scan, there are differences, either underactivity or overactivity. But at the end of the day, there's a randomness. There's more randomness to it than signal.
Yeah.
Meaning that this person with OCD might have some abnormalities in brain metabolism here and here and here, but another person with almost identical symptoms actually has a completely different scan. And how do we make sense of that? And then when you look at different diagnoses, there are no significant differences. Person with schizophrenia can have the same kind of a brain scan as someone with depression, who can have the same kind of a brain scan as someone with alcoholism. And there can be no significant differences between their scans. And so the scans don't tell us diagnosis at all. The scans don't tell us symptoms at all. And here's the kicker. The scan signals will wax and wane. So sometimes it can be normal. And other times it might be abnormal. And that can change from minute to minute, literally, depending on the things that you think or your stressors, if your heart rate goes up, if your cortisol levels go up, if inflammation goes up, any of those things and myriad others probably can all impact brain metabolism on a minute by minute basis. So if you scan a person when they are vulnerable, you might notice some abnormalities in the scan. But if you scan that very same brain an hour later, it might now appear normal.
Wow.
And you don't know which one to believe.
So there's no real pattern there for you to be able to use to just help diagnose and just fill in some of the blanks, I suppose. Like
The overall pattern is the brain scans of people with severe mental illness, on average, will show impaired brain metabolism or glucose hypometabolism. Take your pick which area you want to look at. So it could be anywhere. That's one feature. And the other feature is the brain scans. If you're measuring signals of inflammation, neuroinflammation, you will tend to see higher levels of neuroinflammation in the brains of people with mental illness. But again, where and how severe, it's randomness.
Right.
There's a thing called oxidative stress, which is closely related to both of those other things. So they're all interrelated. Hypometabolism, oxidative stress, inflammation, they all kind of go together, even though they're measuring technically different things. But levels of oxidative stress are going to be higher.
Okay.
And you can measure that in a brain scan. And so at the end of the day,
That's not really telling you, though, what you need to do.
is it clinically useful?
Right.
No.
Yeah.
And we don't need that scan because I can already predict that with almost 100% accuracy by just talking to the person.
Right. I just understand there's some.
You're having hallucinations. You're
We know there's
severely
accident.
depressed.
Yeah.
You're having constant obsessions and compulsions. Well, I already know your scan's abnormal. I don't need a scan to tell me that.
What other theories of mental health would you say are worth kind of calling out? We just addressed kind of brain scans. Is there anything else that you feel like, people should just be aware of that, hey, these theories are half-baked, flawed, however you want to say it, and people should know that?
Before we get into this next section, I wanted to let you know that Dr. Palmer and I cover topics that may be difficult for some listeners, such as self-harm, suicide, and sexual assault. If these topics are not for you, you can use the chapter markers in the description wherever you're watching or listening to skip ahead.
The one that's really important to call out is the theory of trauma and stress. So there are some experts, world-renowned experts, who say trauma is the cause of all mental illness. That if you have a mental illness, it's because you've either had overt trauma that you remember, and if the person says, no, I've actually been fine,
Some latent trauma that's.
they pathologize you. Probably not. How did you feel about your parents? How do you feel about your significant other now? What about in school? And if you really go that route, yeah, everybody's got trauma. Sure, everybody's got trauma. Oh, that's why. Oh, I found some trauma.
Mean girl in high school.
Yeah, everybody's got trauma. My mom yelled at me once. Or that teacher, slapped my wrist. Okay, that was the trauma. Really? Was it?
Yeah.
But not to take away from people who authentically have horrific trauma. So I'm not at all trying to say.
Yes.
There are people who've been raped and abused and beaten and everything, neglected and everything else. And that is, in fact, can be a cause of mental illness. And so what I'm presuming we'll get to when I talk about the metabolic basis of mental illness, it doesn't take away from any of these things that we're talking about. Of course, trauma plays a role because trauma impacts metabolism. So people who have a trauma history, or the more standard way to describe it, people who have adverse childhood experiences, the more you have, the more likely you are to have poor health, all health. The more likely you are to, if it happens early enough in life, you're more likely to have every mental disorder in DSM, all the way from autism to ADHD, to depression, to PTSD, to substance use disorders, to anxiety disorders, personality disorders, eating disorders, dementia, everything else. And, guess what else? You're more likely to have every metabolic disorder. You're more likely to develop obesity, diabetes, cardiovascular disease, and you're more likely to die an early death. And people who have 6 or more ACEs, on average, die 20 years younger than people who have 0 ACEs.
And just spell out our acronyms for us.
So ACEs,
DSM and then ACEs.
So ACEs, adverse childhood experiences. So those are things like extreme poverty, not having food, physical abuse, having someone with a mental illness in your immediate family, having a parent go to prison, parents divorcing, those types of things. DSM is the Diagnostic and Statistical Manual, often referred to as the Bible of psychiatry, has lots of different diagnostic labels.
Excellent.
So trauma and stress absolutely play a role in mental illness. But here's the thing. So people will say, well, then we've got treatments for that. And the treatments are pills and psychotherapy. Well, I can tell you now, based on the best data we've got, the pills are not all that great.
Mm-hmm.
You're 30% at best. And then the other type of treatment is psychotherapy. And there's a widespread belief that, well, if you just talk about the trauma, that'll fix you. Just get it out. Vent. Cry. Do whatever you need to do. Get angry. Yell. Hit a wall. Punch a pillow. Whatever you need to do. Just get it out. And if you get it out, it'll be fine. And that's largely based on kind of psychodynamic principles that you've somehow repressed these traumatic feelings or memories or experiences. And if you can make them conscious, and somehow everything will just magically work itself out.
Where does that fall down?
It doesn't work. For if any of your listeners are listening to this thinking, no, that worked for me, great. I'm happy for you, and that's great. There are some treatments that do work, and I'm not necessarily even opposed to the psychodynamic ones. It's for some people that can be a powerful treatment. For others, they can do trauma-informed kind of behavioral therapies, cognitive processing therapy, other types of trauma-informed therapies can be helpful. But again, when you look at the long-term outcomes, many people, like more than 60% of people, are not getting better when they're getting those treatments. And so we need new ideas and new solutions and a new way to understand how trauma impacts human biology. Yeah. Because I'm not at all trying to suggest that trauma isn't a legitimate factor. It absolutely is a legitimate factor. But talking about the trauma is not enough. Right. Giving people SSRIs is not enough, more often than not. So instead, we need to understand the biology of what is trauma doing to the cells in the brains and bodies of those people, that it can result in essentially every mental disorder and every metabolic disorder. And to me, that is such a profound and obvious clue.
If there's one thing I've just been reminded of when launching Science and Soul, it's that whenever you're starting something new, you've got to be prepared to wear a few different hats. Whether you're building a brand, launching a podcast, or bringing your side hustle to life, unless you've got a team behind the scenes, you're it. You're the engine, the creative, the strategy, the execution, which leads me to today's sponsor, Shopify. Shopify is a tool that not only helps you get started, but wears a lot of those hats for you. It's your design studio where you can browse templates and customize them to your brand's aesthetic. Your content creator, writing product descriptions, page headlines, and thanks to AI, can actually enhance your product photos. And of course, it's your commerce expert, managing things like inventory, international shipping, returns, and so much more. If you're ready to sell, head to shopify.co.uk/Kristen to start your $1 per month trial. That's shopify.co.uk/Kristen. Today's conversation is sponsored by Whoop, where I work as the global head of human performance principal scientist. Lots of us set resolutions in January, but the best time from a psychological and physiological standpoint is actually in the spring. Because our bodies are wired to respond to environmental cues, variables like daylight increasing and temperatures getting warmer give us a natural uptick in energy, mood, and motivation, creating a very real opportunity to engage in more movement and a stronger routine. With summer nearly here, right now is the time to really get intentional and start training to hit your health goals. Tools like Whoop Coach, trends, and weekly plans will give you insight into what is working and what needs improvement. I'm always looking at my recovery and my heart rate variability trends, or HRV. They're amongst the clearest signals of how well I'm aligning my behaviors with my values. If you'd like to explore your data, visit join.whoop.com/science to try Whoop free for 1 month. That's join.whoop.com/science. When was that aha moment that you were like, wow, this is the link. This is the missing link?
There were a few aha moments along the way, because it really was an iterative process that wasn't always so clear to me. I think the first link for me was that I had seen patients who had chronic psychotic disorders, the kind of patient that we were talking about, these untreatable, or these patients that, untreatable is so horrible to say. Some clinicians will feel that way, like they treatment resistant. It implies that the patient is resisting our treatments. The better way to frame it is our treatments are failing them miserably. But these patients who just were not getting better despite treatment after treatment. So I had a couple of them early on have what was nothing short of miraculous improvement by using a ketogenic diet. And that sent me on a path to try to understand what on earth happened and how can I understand it at a scientific level.
Did you stumble on that dietary strategy kind of by accident? Like how did you know, okay, we're going to try a ketogenic diet? It just kind of seems random,
I had suffered with mental illness myself as a kid and young adult. By the time I was in my mid-20s, I had, even though I was not officially overweight or obese, and that certainly wasn't obese, I had metabolic syndrome.
Wow. So you're
pre-diabetes,
pre-diabetic.
Hypertension, like 160/110 hypertension.
Whoa.
I had horrible lipids. My triglycerides were over 300. My HDL was like in the 20s or 30s.
You're in your mid-20s.
Yeah, mid-20s. In medical school, I am following a super, super low-fat diet.
Wow.
Like almost no fat.
Doing everything right.
Almost no fat in my diet, because at that point in time, there was no such thing as a healthy fat. All fats were bad. And the reality now, as I look back in time, the reality is I also had my own mental health struggles. How much of that might have been due to a poor diet?
Yeah.
I grew up drinking Kool-Aid, never drinking water. If we drank milk, it always had to be flavored with something that had sugar in it, chocolate or strawberry. But I would never drink plain milk. Why would you do that? And hamburger helper and all sorts of other highly processed foods. That's what I grew up on. So who knows how much of that played a role. But the reality is I already had mental illness. And then I certainly had some traumatic events through the way. I ended up leaving home before I finished high school. There were lots of things going on. So by the time I'm in my 20s, now in hindsight, I can actually look back at my history with a little more compassion and feel like, well, maybe it's not that shocking after all that you had metabolic syndrome. But for whatever reason, I kept trying low-fat diet. I kept exercising year after year. My doctor's saying, diet and exercise. Chris, you're doing it wrong. Clearly you're doing it wrong. I'm like, no, I'm doing exactly what you're telling me. It's not working. He's asking about family history. Oh, well, if your parents have this, then it's genetic. You just have to take medicines. And I really resented that. I wanted to try to do it without pills. And in an act of defiance, I went on the Atkins diet. which happens to be a low-carb ketogenic diet. Kind of did more of a South Beach version of it, probably, even though the South Beach diet wasn't yet published. And within a few months, my metabolic syndrome was completely gone.
Atkins is basically just unlimited animal protein.
Atkins, the definition is really fewer than 20 grams of carbs a day.
Okay.
It can be with or without fats, with or without a lot of proteins. I mean, protein and fat is primarily all you got to work with.
Right.
So it's got to be one or the other or both.
Protein and fat, yeah.
But you could do a vegetarian version of an Atkins diet. You could do a more fat-based version of it, which is very ketogenic. You could do an all-you-can-eat meat buffet, and that carnivore diet is what it's called now. And, back in the day, we did that. Like over the years, if I wanted to rapidly lose weight, I just noticed just eliminate all carbs.
Yeah.
Which is all plant-sourced foods. And if I only eat meat, then I lose weight pretty rapidly. So lots of versions. But the thing I noticed was that my mental health went through the roof.
Wow. So mood, everything, just
mood, energy, focus, concentration, sleep. My sleep got so much better.
Yeah.
It was dumbfounding.
Yeah. We know that that's a bidirectional relationship, big time. I spend a lot of time looking at sleep and psychological functioning. And I mean, there's just no question that when that goes offline, you're screwed.
You are. And even if you gave me somebody who's perfectly healthy, if you sleep deprive them for 3 days in a row, like severely sleep deprive them, they're going to be a mess.
Yeah.
And there's a high likelihood they're going to start having hallucinations, delusions, mood changes, depression, mania, something. Like bad things are going to start happening quickly.
I mean, that circadian misalignment is like when you look at the mechanism, when you look at the pathway to metabolic dysfunction, a lot of it is suppressed or reduced melatonin production. Because when you have reduced melatonin production, of course, like you're insulin resistant, right? And then that's, the next step is, metabolic syndrome, right? So it's like once your sleep becomes disrupted, so your circadian rhythms become misaligned, that melatonin production becomes suppressed. Like it's just like you're going down a path pretty quickly.
You are. And it does become a bit of a spiral.
Yeah.
Because now you're depressed, you're anxious, you're ruminating. You've had a few days or a few weeks or a few years without good sleep. So you're terrified of your bed now. You hate going to bed.
Yeah.
Because it reminds you of the place that you are stuck and trapped in all night,
Right.
trying desperately to sleep. And your mind is just racing with all of the worries of your life. And in the middle of the night, especially when you can't sleep, that is the time of day that we are most pessimistic. So if you try to solve a problem,
Right.
like when you're wide awake at noon, most people can be a lot more resilient than they can be if you're trying to solve that same problem at 2 a.m.
Right.
in the midst of insomnia. That exact same problem with that exact same human being with the same cognitive capacity will be doom and gloom at 2 a.m. And then when they think about it again at noon the next day, they're like, why was I so freaked out about that? I mean, yes, it's a problem. Yes, it's a stress, but I can manage it. And it won't be a catastrophe if it doesn't work out. Like, it's okay. But somehow, in the middle of the night, it just felt like my life is going to be over if that.
So your personal experience with Atkins, basically, you saw all of your markers of mental health improve. So what was kind of this, you have this moment. How did this translate into kind of your work with your patients? And, maybe just a few case studies because they're like mind blowing.
So initially I was not at all prepared to start using it with patients. So I just started with friends and family. They were my guinea pigs.
Nice.
And they were the ones seeking me out. They were like, well, Chris, you look so good. You seem so happy. You lost some weight or you improved your health or you just have so much more energy and you're so positive. what are you doing?
This is your sister, right?
And yep,
Yeah.
sister and sister-in-law.
Nice.
And early on, they were really mad. They were just frustrated that, like, why don't we have health like you have? And so that same sister has done low-carb diets,
Yeah.
ever since. And she and I are kind of on a similar trajectory.
Amazing.
And then I started using it with patients. So I have these patients in my clinic who've tried 30 plus psychotropic medications. They've had ECT. They've been in and out of hospitals. They've had decades of psychotherapy, and they are still suffering from crippling depression, suicidality, other things. And so I remember one of the very first patients I treated was that. I certainly did not at all try to force it on any of the patients. I was just like, hey, we've tried so many things. With that particular patient, it's funny because I had been trying for over a year to get her to exercise.
Wow.
And she wouldn't. And she kept saying, yeah, at one point, like I would bring it up every now and then. I wasn't like totally harping on her, badgering her about it. But at one point I brought it up one too many times. And she said, Dr. Palmer, listen, I am severely depressed. I am lazy. I don't want to hear about exercise anymore. I know you mean well. I know I'm sure I've seen the studies. I know why you're telling me. I believe it, but I'm never going to do it. I'm just lazy, and just stop making me feel guilty about it. I said, okay, loud and clear. I've heard you. I won't bring it up ever again. So then like 6 months later, I'm like, how about a diet?
6 months later, it's like the timeline on these. Wow.
There's this low carb diet thing that I've been experimenting with, and I've seen some people actually get better with. I, of course, don't share my own personal story.
Yeah.
I've seen some people have mood improvement, and you've tried so much, and you are suffering. I mean, she would just come in just sobbing through the session, how she wants to be dead, how she can't take it anymore. Why should she try to stay alive? What does she have to live for? Her life doesn't matter. And so it was like heartbreaking for me to sit with her week after week after week, prescribing pill after pill after pill after pill and other treatments along the way, and she's just not getting better. So I'm like, how about a diet? Would you consider making some dietary changes? Early on, she's like, no, that sounds too hard. Nope, not going to do it. But she would, tell me more about this thing. What do you want me to do? How hard is it going to be? Ultimately, after lots of talking education, so it's not like I said, try a diet, and she went out and tried a diet. Let's be realistic.
Yeah.
Took probably a few weeks or a month or so to kind of motivate her.
See the idea.
To want to make a change.
Motivate.
She finally makes the decision, okay, I'm going to try it. It was actually hard for her to get into ketosis.
Right.
It took a little bit of time, but we finally got there.
And are you pricking the finger, or are you
at that
urine test?
At that time, I don't even think we had blood meters. So this is way back in time.
Yeah.
This is probably like 20 years ago.
Okay.
If there were blood ketone monitors, I didn't know about them. But we had the urine strips.
Okay.
So we were using the urine strips, so we could tell. And within a week or two of getting into ketosis, I actually remember she became hypomanic. She was giddy.
That must have been a new feeling.
Laughing. She started dating. She was meeting men, dating. I'm like, what the hell's gotten into you? Oh my God, this is amazing. And we brought it down, and it was good. But I remember even at that point, this is a legit treatment. Oh my God, I can't believe you are no longer depressed. When ECT, 30 plus psychotropic meds, decades of psychotherapy couldn't do anything for your depression and suicidality. I change your diet and you're now. So I kind of laid low with all of that for years. Because at that point in time, there were doctors losing their licenses for prescribing the Atkins diet.
Wow.
There were literally doctors losing their licenses for such heresy. Like, how dare you prescribe that diet? I mean, at that point in time, this was the late 90s, early 2000s. So at that point in time, we did not have controlled trials of the safety or efficacy of the Atkins diet or low carb or ketogenic diets for weight loss or diabetes or anything else. So, and it was largely considered this is a dangerous, reckless diet that will kill people. So I just laid low. I was still using traditional treatments with a lot of my patients, but every now and then when patients weren't doing well and I thought they might benefit from a dietary intervention, I was just saying, hey, are you interested? Happy to help if you are. And it was really in late 2016 that one of my patients with schizoaffective disorder, chronic, severe, crippling mental disorder, he can't function. He's tormented every day. He weighs over 340 pounds, likely because of all the pills we had prescribed to him. He's a hermit. He's terrified to go out in public because they're all after him. They're all trying to hurt him. He gets it in his head, I'm never going to get a girlfriend if I don't lose some weight. And I'd like to lose some weight. And I'm like, okay. Of course I'm thinking like, yeah, I don't know how. Number one, I'm doubtful you're going to be able to lose weight. Number two, like, is that really the only problem?
Yeah, I know.
You got a lot to work. You got a lot of other work to do.
Yeah.
But I'm trying to encourage him, and I'm like right there with him. Like, hey, you've got an idea to improve your health. I'm right there with you. Absolutely. Let's do it. And he had already tried a few other weight loss methods that did not work for him. I knew the ketogenic diet well, so I'm like, let's just try the keto diet. Now with him, I had zero expectation that it would do anything. I didn't even expect it to have an antidepressant effect in him because he didn't have depression. He had schizoaffective disorder. He was a zombie from all the high-dose antipsychotics, mood stabilizers, tranquilizers, and everything else he was on. So I had zero expectation that it would do anything for his mental health. Because in my mind at that time, he has a completely different disorder than these other people. They are worlds apart. And it's just sad and unfortunate and tragic, just like my mom. Like, we just don't know how to help you. There's something wrong with your brain, and we just don't know what it is, and we have no idea how to make it better. I'm so sorry. I'm so sorry. We just don't know. It's not that I don't want to help you. It's not that I'm not trying my best, but I just have no idea what's wrong with your brain. And I know that the treatments I'm going to give you aren't going to work. But I did think, well, keto might help him lose some weight.
Yeah.
So, and he's got in his head he wants to lose some weight. Let's go for it. We try the ketogenic diet. Within 2 weeks, he starts lighting up in a way that I had never seen in the 8 years I'd treated him. He starts smiling more. He's making better eye contact. He's got like this sparkle in his eye. He's really talkative. Not in a hypomanic or manic way, but like he barely talked before. Now he's got all sorts of things to say. And I'm like, oh my God, what got into you? You're coming to life. Like, you're coming to life. I didn't know this was in you. I didn't know this person existed. And I'm so delighted, but he's still delusional, still hallucinating, all of that. So I'm like, wow, he did get an antidepressant effect. Wow, that's great. We're going along. He's losing more and more weight. And it was at about the 2-month mark that he just spontaneously starts telling me, Dr. Palmer, you know those voices that I hear? I'm like, yeah. He's like, they're going away. I like barely hear them anymore. They're not really talking. And when they do talk, I just ignore them now. I'm so sick of those voices. I'm not giving them the time of day anymore. I'm just so sick of listening to them. And then another 2 weeks go by, and he says, Dr. Palmer, you know how I always thought that there were these families who were conspiring against me? And he goes on about all these paranoid conspiracy theories that I'd heard about hundreds of times. He's like, you know what? I don't think it's true. Now that I kind of think about it, it sounds kind of crazy. Maybe it never even was true.
Wow.
Maybe I've had schizophrenia, like everybody's been trying to tell me all along. And maybe it's going away. So he went on to lose over now 160 pounds, has kept it off 7 years and going. He, for a period of time, was able to move out of his father's home. He is able to participate in many activities in the community, use public transportation, do things that he had never been able to do. The real answer is he's not fully cured. He's not. We're still, to this day, trying to get him off medicines that he has been stuck on. He started medicines when he was a very young child. And so his brain is adapted to those medicines. He grew up, his brain developed with those medicines in his system. And so by no means do I want people to come away from that story. There are other stories that are essentially a cure for all intents and purposes. Unfortunately, his isn't there yet. We are fighting like hell to get him there. And as he sees more people coming out, like, that one got cured. What about me? What about me? I'm like, I'm fighting with you. I'm not giving up on you. We are gonna get there. But getting people off psychiatric meds when they've been on them their whole life is not at all easy. So 2 of these cases I reported in a research journal called Schizophrenia Research, which is a respected journal. 2 of the patients, those 2 patients, put their schizophrenia into full, complete, lasting remission off of antipsychotics. So in my mind, this opens up an entirely new way to think about mental illness, and it opens up entirely new strategies to treat it.
How many folks who go for treatment for some mental health disorder in parallel have metabolic dysfunction?
It depends on how you define metabolic dysfunction. So if you talk full-fledged metabolic syndrome, again, it's hard to quantify because it depends.
It's on a spectrum.
What illness or what label are we talking about?
Yeah,
When did they measure those biomarkers? When did we do? So instead, I'll just talk generically about the U.S. population, which you probably already know.
Yeah.
93% of American adults have at least one of the biomarkers for metabolic syndrome, meaning, lipids, prediabetes, abdominal fat, or blood pressure. At least one of those is abnormal in 93% of U.S. adults. There was a large kind of cohort study, I think they used the UK Biobank, that was following people serially and continues to follow people serially. And they get regular biomarker assessments. And then people are monitoring their health. What health conditions are you developing? Did you have a heart attack? Did you have cancer? Do you have mental illness? Do you have depression? Do you have anything? That study over a decade, I think, following people over a decade, they looked at glucose and they looked at lipid markers and inflammatory biomarkers. So all highly correlated, even though inflammatory biomarkers aren't officially part of metabolic syndrome, they are highly correlated with metabolic syndrome. So they looked at those biomarkers, and what they found was that in patients who had new onset mental illness, in the 1 year before that mental illness began, their metabolic biomarkers were deviating from the norm.
Wow.
Meaning the blood glucose was going up even before the person knew they were clinically depressed. Their triglycerides were going up even before they knew they were clinically depressed. Their HDL cholesterol was going down even before they knew they were clinically depressed. Their inflammation was going up. And that is a pretty strong signal that metabolic abnormalities or dysfunction for some people can be the first overt sign of what is an impending mental illness.
Are you using GLP-1s at all in your practice?
So I have one patient who's a type 2 diabetic who's on them through his primary care doctor, but I'm not opposed to GLP-1s, but I'm not actively using them right now. There's a lot of hype about them in the mental health field, in particular for addiction.
Yeah.
But there are clinical trials underway for Alzheimer's disease, for depression, for bipolar, schizophrenia. So they're becoming kind of the everything drug.
Yeah. It's going to be really interesting to see how that evolves, and how that might be able to support, people who have these metabolic disorders, and if that's a path to just stabilizing, some of the mood and, affect and, it'd be interesting to see if that helps people.
It will. And I mean, there are some early signals that they might have antidepressant effects in patients who are using them for type 2 diabetes. There was a scare several months ago that they might increase suicidality and in rare cases, but they might increase suicidality. And I think the FDA is looking into it. European medical organizations are looking into it.
What would be the mechanism there?
That's the interesting thing. The easiest, so the mechanism, wildly speculative right now.
Okay.
The easiest analogy I offer are antidepressants. So antidepressants
Right.
are intended to reduce depression and reduce suicidality. And they're prescribed to millions of people in the hopes that this will reduce your risk for suicide. And yet, right there on the package insert issued by the FDA, this medication might increase suicidality in some people. Metabolism is like Goldilocks. You need the right amount, not too much and not too little. And there can be adverse consequences when a metabolic biomarker or regulator is too little or too much. And that's the way I think about SSRIs. That's the way I think about GLP-1s and others, is this concept that you can just flood the system with more and more and there are no adverse consequences is ridiculous.
Yeah.
Like anybody with common sense should know that almost every medicine, even multivitamins, if you can overdose on multivitamins, it won't necessarily be fatal, but it will not be good for your health to have sky-high levels of vitamins in your system. And with other things that are relatively benign, Tylenol, you can actually overdose in a fatal way on Tylenol. Right. So things that most people think are benign and fine and safe actually are not always safe when you take excessive doses. Right now, we kind of don't know, well, what would be an excessive dose of a GLP-1? Yeah. I mean, right now, I think most people are kind of like, no problem. And there are, the clear example is that as you go higher and higher, you do start to get dysfunction in the gut motility. And so some patients can actually have almost paralysis or something
Yeah.
of their stomach,
Yeah.
and that's not good.
No, it's not good.
That's not good for you, as far as I look. Last
mean,
time I looked.
That's the thing. Like any drug you're putting into your body is going to affect your gut biome, which will have a direct effect on your brain.
Yeah,
I mean, this is kind of the basis of, your theory, right?
yeah.
Like, it's just, how do you look at, like, when you zoom out and, because you're in this profession really, and I think the default is to medicate, right? I mean, that's just what our world is incentivized, our medical system is incentivized, right, to medicate. I think people get really, really defensive, when you suggest that there are alternatives to medication. How do you respond to kind of that immediate pushback and that kind of, violent reaction that we need to be more accepting of medication?
If you're benefiting from medication and doing really well on it, congratulations. Keep doing it. By no means do I want to stand in the way of you accessing this medicine. Can we offer medicines to other people? Sure, we can. But I will say, but please do your homework. I work in one of the top-rated psychiatric hospitals in the nation. And I see patient after patient after patient, year after year after year, not getting better with those medicines. So don't ignore them. Don't deny their existence. Don't gaslight them and try to tell them that if they really wanted to get better, they would be better because the pills work for everyone. That is disrespectful to millions and millions and millions of people who are suffering, whose lives are ruined because the pills aren't working for them. We need better treatments for them.
It's wild when we look at our data. We have hundreds of thousands of people on the platforms. We have millions and millions of, data points around sleep and activity and, all the physiological markers. And when we look at, high fit versus low fit, they have a fundamentally different sleep architecture. The low fit people, they drop into REM faster. They have decreased REM onset latency, which is a feature of depression risk. So when you think that exercise and diet they impact sleep, which then impacts your metabolism. Like, think this is not connected, and that is not the first place we should be looking. That seems crazy to me.
It does. I think,
and I know it's hard to get people to do things. Like, I get that.
It is, but so I'll push back. And based on our conversation, our conversation is a perfect example of why people are skeptical. Eat a healthy diet.
Yeah.
Well, what exactly is that, Dr. Palmer? Entenmann's?
Low fat. There's a gazillion dietary strategies.
Is it Entenmann's and a super low fat diet like you were on? Because if that's a healthy diet, it actually makes your metabolism worse. It certainly wasn't helping my mental health. When I did a dietary intervention, it dramatically improved my mental health. I don't see that as proof that diet was the sole cause of my mental struggles, because the trauma played a role and other things were playing a role. But I do see it as the ketogenic diet can dramatically reduce inflammation, can change my gut microbiome, can improve mitochondrial function, can do lots of things that might ameliorate whatever the root cause was. And I have every reason to believe the diet I was eating was not healthy. So it may very well have been diet, but I'm not certain that it was just the diet. Again, I don't blame people for being skeptical, because we've been told over and over again, and we're still told, don't eat any animal source foods. Animal source foods are bad for you. And the recent Dietary Guidelines Committee is coming out saying, when it comes to protein, basically eat all plants. And when it comes to protein, put at the very bottom animal source proteins. get your proteins from beans and peas. So they're basically saying be vegan. If you look at the epidemiological data on vegan diets, vegans are much more likely to have poor mental health.
Is that just a vitamin deficiency
It
issue?
almost certainly is a vitamin deficiency.
Yeah.
So vitamin B12, iron, choline, and other vitamins and nutrients that are primarily and or exclusively found in animal source foods. I have no problem with somebody who wants to be a vegan. If you want to be a vegan, I have really great friends who are vegans. But if you want to be a vegan, but understand the risks that you're taking and understand how to mitigate those risks. And that means appropriate supplementation with to make sure that your nutrients are good. And then get assessments. Get assessments every 6 months or a year. Like, don't just rely on, I'm taking my vitamin, I should be good. Get your assessments and make sure you're good.
It's a blood panel along with, whatever evaluation you need.
Yep.
Psychotic.
Yep.
Is that taught?
No.
Yeah.
No. And again, as I said,
It's wild.
Dietary Guidelines Committee's coming out with no responsible communication about, if you're going to follow our advice, make sure you take a B12 supplement and a choline supplement and an iron supplement and a this and a that and the other. No responsible communication. I mean, even the governor or the mayor of New York City has implemented like vegan lunches in schools. It's fine, but are you also giving them a B12 vitamin when you're doing it? Like it there's this assumption that there's a one-size-fits-all healthy diet and that there are no risks with any dietary intervention. There are risks with ketogenic diets too. First to say it, there are definite risks with ketogenic diets. By no means am I trying to say keto's perfect and vegan is bad. Not saying that. But if you're following a ketogenic diet, get help, get supervision, understand what you're doing, understand what the risks are, and make sure you mitigate against them.
Are there any studies happening right now that are looking specifically at ketogenic diet or any other just, restoring healthy mitochondrial function? Like, are there any kind of studies that are looking squarely at that?
Countless.
Okay, good.
Which is great.
That's great.
So on the latter question, there really are countless studies looking at new medications, supplements, vitamins, other lifestyle other things, how we can improve mitochondrial function. On the question of the ketogenic diet, so we just the team at McLean Hospital and Harvard Medical School and I just published a systematic review of the ketogenic diet for mental illness, over 50 publications of pilot trials, randomized controlled trials, some of them just case studies, but over 50 reports in the literature, the peer-reviewed medical literature, over 1,900 patients represented in that, and clear benefits. Overall, clear benefits, mood stabilization, antipsychotic effect, antidepressant effect, anti-anxiety effect, cognitive improvement. And there are now about 20 controlled trials of the ketogenic diet for mental illnesses, with 8 of them being randomized controlled trials underway.
It's amazing.
Largely funded. I need to give a shout out to the Bazooki family and Metabolic Mind, basically largely due to philanthropy from this one family whose son benefited greatly from ketogenic therapy for his bipolar disorder.
Amazing.
They have spent over $60 million on research now. And so my hope is that over the coming year or two, we are going to see more and more publications on this, and we'll know.
Yeah.
Like, we'll know it. I'm not even going to say what the conclusion is. I have my bias because I've seen it work.
Yeah.
So I'm hopeful, fingers crossed. but let's see what the randomized controlled trial data shows. And
Are there any biosex differences in terms of responsiveness to this treatment?
there are definitely huge differences in terms of gender, sex hormones, probably reproductive capacity, and it's and the effect of the ketogenic diet on all of that. And as a rule of thumb, like if I take people who don't have a mental illness, it's a heterosexual couple. They both go on a ketogenic diet together to lose some weight. More often than not, the man says, I love this diet.
Yeah.
It's great. I feel great.
Yeah.
And the woman's like, oh my God, that sucks.
Mhm.
I
Yeah,
felt
totally.
awful. I
Yeah.
like it. Yeah.
And all the top exercise scientists who study female physiology will say no ketogenic diet. Well, some of them will say that it's harmful for both men and women. And this is where, again, our fields of exercise physiology and psychology are siloed. And this is a problem because they interact. That's why I'm a psychophysiologist. But it kind of drives me crazy because I just think it's a little myopic in terms of like the viewpoint, right? But please go on. Yeah.
It is.
Yeah.
And so I want to acknowledge that truth that if on average, if any gender is going to have a problem with it, it's likely to be women over men. But with that being said, the 2 case reports that I published in schizophrenia research were 2 women with long-standing schizophrenia who achieved lasting remission off antipsychotics by using a ketogenic diet.
Yeah.
There's a woman named Lauren Kennedy who has a YouTube channel it used to be called Living Well with Schizophrenia.
Wow.
She has been diagnosed with schizoaffective disorder chronically. She basically posted a YouTube channel about how can you make the best of it. If you're in this boat with me, how can you make the best of it? She has thousands of followers. I think maybe hundreds of thousands. I'm not sure what the numbers are, but she's got a big following. She's such a kind, brilliant, compassionate woman. But was really telling the story about what's it like to live with schizophrenia. And how can you not let it get you down? Don't be defeated by it. I remember like 2 years ago when my book came out, she had me on the podcast. And we were talking about ketogenic therapies. And she actually said, I tried the keto diet for a month and it didn't do anything for me. I didn't say it out loud, but I thought to myself, well, what exactly did you do? Like, what did you try? And a month probably isn't enough. And I mean, I'm going through like, did you really try it? Because I'm not sure. Like, I would need to know more, but I'm not going to say that publicly on a podcast. And well, fast forward, as this field has been growing and as more people are talking about it, about a year ago, she decided to embark on a ketogenic diet with medical supervision. She is now in full remission off antipsychotic medicines.
Wow.
And she has basically documented her journey on video. So she's a woman who has thrived. Like her life has been transformed with ketogenic therapy.
Yeah.
Now that doesn't take away whatever is happening to these other women.
Yeah.
With hormone dysregulation
A lot
or
of individual
mood sensitivities or other things. I'm not trying to say that that's not real, but I wouldn't at all want any woman with severe mental illness to come away from this conversation like that's not for me.
Right. Good.
Because it has transformed some women's lives.
Yeah. I want to finish with a final question. And I'm so curious to know how you might answer this. What does being human mean to you?
I think some of the core pieces for me are just awareness,
Mm.
the ability to love, and the desire to be accepted and loved.
Mm.
And I can think of humans that lack one or more of those. And so I cringe at almost trying to suggest that they're not human.
Mm.
But I think those are some of the core requirements. And it doesn't have to be like they have to love in a neurotypical way and everybody else is somehow not human. That's not at all what I mean by that. Different people are going to love and want to be accepted in wide-ranging ways. But yeah, I think an organism that is aware that kind of they exist and they're in a space with other living organisms.
Mm.
And then this desire to be part of it
Mm.
and to be accepted, to be wanted. Yeah. I don't know.
Yeah, that's beautiful. Thank you.
Absolutely. Thank you so much.
I want to take a second to talk about our sponsor, Huel, and one of their products that has been game-changing for me. Most of you listening will know that the food we put in our bodies impacts how we perform. Our energy levels, ability to stay focused, to recover, all of it is dictated by our nutrition. But for many of us, we're short on time, and time is often one of the biggest barriers when it comes to eating well. For me, between my job and launching this podcast, my family, there are days when I feel like I only have minutes to grab something to eat. On those days, I have Huel Black Edition ready to drink. Firstly, because it's a balanced meal with 35 grams of protein and 27 essential vitamins and minerals, and it's low in sugar. Secondly, it tastes like a milkshake, and it's hardly surprising that Huel has sold over 500 million meals. If you've never tried Huel, take this opportunity and get 15% off by visiting my.huel.com/Kristen Holmes and use code Kristen. You'll get a free gift with your first purchase. Terms and conditions in the description.